A very good afternoon and a good evening to everybody present here. I, Darshika Shah from the Clinical Engagement Team, welcomes you to this special webinar commemorating the World Kidney Cancer Day. And today we gathered here to shed light on the latest advancements and trends in kidney cancer management, with a particular focus on two crucial aspects: kidney cancer in children and advancements that are shaping the future of kidney cancer care. Kidney cancer is also known as renal cell carcinoma, which is a significant health concern affecting millions of individuals around the world. This global observance serves as a reminder of the importance of awareness, early detection, and effective treatment strategies in combating this disease. We hope you have attended our sessions yesterday. In case you missed them out, you will find them links below. Moving ahead, I would like to welcome you to this panel discussion on advancements in diagnosis and management of kidney cancer on the occasion of World Kidney Cancer Day. Today, we have two esteemed experts with us, a medical oncologist and a surgical oncologist, who will be sharing their insights and expertise on the same. So let's start by introducing our panelists here. Our first panelist is Dr. Samir Gupta. Hello, sir.
Hello.
He's a professor and head of the Department of Surgical Oncology at Dr. D.Y. Patil College and Hospital Research Center in Pune. He's a reputed surgical oncologist with more than 3 decades of experience in his field, and he's an expert in advanced oncosurgeries and laparoscopic surgery. Dr. Gupta has a distinguished career as a surgical oncologist in various hospitals of the Indian Armed Forces, articles on cancer, both in national and international reputed journals. It's a pleasure to have you with us here, sir.
Same here.
Thank you, sir. Our second panelist here is Dr. Nikhil Krishna Haridas, who is currently an assistant professor and consultant at the Department of Medical Oncology and Hematology Division of Stem Cell Transplant at Amrita Institute of Medical Sciences. Dr. Nikhil is a renowned medical oncologist who has performed over 20 allogeneic stem cell transplants, including haplo transplants, along with the autologous stem cell transplant to date. His special interests include stem cells and other cellular therapies, gastrointestinal oncology, genitourinary urology, and molecular oncology, etc. He's also a registered member for the several prestigious institutions such as American Society of Clinical Oncology, European Society of Medical Oncology, and Medical Oncology Forum in Hyderabad. In addition to that, he has researched extensively on novel baseline prognostic index in non-Hodgkin's lymphoma. So to set the context today, I will now begin with an overview of kidney cancer. Dr. Nikhil, could you provide us with a brief introduction to kidney cancer and its prevalence in India?
Thank you, Darshika, for this opportunity. As we are all aware, the 15th of June is celebrated as a World Kidney Cancer Day. And I actually like this year's theme that we have to learn to live with kidney cancer. We have to talk about living with kidney cancer. Now, when you talk about kidney cancers, as you correctly mentioned, most of them are renal cell carcinoma, close to 90% of them. The other subtypes include lymphoma and sarcoma of the kidney. We also have the pediatric kidney cancer that is called as a Wilms tumor. Now, when we talk about kidney cancer, so mostly we refer to the renal cell carcinoma because many subtypes. The commonest subtype, which is more than 85% of the cases, are going to be a clear cell carcinoma of the kidney. Other rare subtypes like chromophobe, papillary subtype, collecting duct type are all described in a textbook, and we do encounter them in our day-to-day practice. The World Kidney Cancer Day is set up to make people, to increase the awareness about early detection and management of kidney cancer, as most of these diseases asymptomatic.
Yeah, I would like to add to that, Darshika. Dr. Nikhil has very, succinctly pointed out the importance of the World Cancer Day. And what is important to note is that the incidence of kidney cancer is increasing. And more kidney cancers are being detected incidentally. That is, you go and get an ultrasound done for something and you find that there is a mass in the kidney. So therefore, the importance of detecting renal cancer early and treating it is very important. And that is why, and since the incidence or the number of patients with renal cancer is increasing, So this has become more important every day.
Sure, sir. I think thank you so much, Dr. Nikhil and Dr. Samir for adding on. So now let's dive deeper into the advancements in the diagnostic techniques. Dr. Samir, could you, Dr. Gupta, if you could shed some light on this aspect?
Yeah. So basically, the diagnosis of renal cell cancer or renal cell carcinoma is because due to ultrasound of the abdomen. Generally, it is detected by an ultrasound of the abdomen, and most of the renal cancers, unfortunately, are detected or used to be detected when they were quite advanced. The patient used to present with the blood in the urine, which is known as hematuria, or with a mass or pain in the flanks. But nowadays, with there are newer tumor markers which can be detected in the blood or in the urine, which can be used to detect renal cell carcinoma. But the problem with that is that these have not been validated in a large randomized trial. So large-scale use of these tumor markers to detect renal cell carcinoma has not yet come into. Dr. Nikhil, you want to add something?
No, sir, that is perfectly put. Right now, I think in India, there is a underreporting of the cases. There is a male preponderance in the ratio of 2:1. And as sir mentioned, you every 2 out of 1 lakh male have a probable incidence of kidney cancer, but we may be underdiagnosing it. And as sir mentioned, some of them are detected. When they become symptomatic, they are mostly advanced disease. And the biomarkers are not yet validated for a day-to-day application, unlike some other diseases like prostate, etc.
Sure, sir. Thank you so much. I think you both of you did talk about the diagnosis bit and how the cases are being underreported. So, what are the primary risk factors associated with the development of kidney cancer, and how do they inform screening and prevention strategies? Dr. Gupta, if you want to start, sir.
Yeah, sure. So, see, the risk factors means those factors which lead to an increase in the risk of developing renal cell carcinoma. So, primary amongst that will be smoking. We find that the relative risk of developing renal cell carcinoma in smokers is almost 1.3 times. So, even people who have were smoking earlier and now have quit, still they have an increased risk of developing smoking. So smoking is that is one of the biggest risk factors. Second is hypertension. Hypertension, patients who have hypertension are known to have an increased risk of developing renal cell carcinoma. Other risk factors are like increased body mass index or obesity. So that is one. Then there are other risk factors like there are familial cancers. That is, there is a genetic association with certain diseases like familial polycystic disease of the kidney or von Hippel-Lindau syndrome. Then there are uses of drugs like the non-steroidal anti-inflammatory drugs like phenacetin, aspirin, and other drugs like brufen. So these are the drugs whose prolonged use and heavy usage has led to or is associated with development of renal cell carcinoma. So these are some of the important factors. Dr. Nikhil.
Yeah. Over to you, Nikhil. If you want to add something?
Yes. Sir has covered the common causes. Of course, the familial or genetic causes, including polycystic kidney disease and diseases such as von Hippel-Lindau and the inherited kidney cancer syndromes, constitute only 5%. So if you see most of the risk factors such as, uncontrolled diabetes, of course, first and foremost, I should have mentioned tobacco usage, hypertension, all these are modifiable risks to a certain extent. While the relative risk doesn't come down once you stop smoking for a person who has been smoking more than 10 pack years, but it is much lesser than a person who continues to smoke. So again, I think as with a lot of other cancers, one take-home point should be, cessation of smoking. to reduce the risk of kidney cancers. Proper control of this non-communicable diseases such as diabetes, hypertension would play an important role in maybe reducing the risk of kidney cancers. And over-the-counter usage of NSAIDs such as Brufen, ibuprofen, etc., also should be regulated.
Sure, son. Thank you so much. Dr. Nikhil, my next question is to you, sir. So we also have a lot of nephrologists watching us live here. So how does kidney cancer commonly present with renal manifestations? And what are the key clinical signs that a nephrologist should be vigilant about during patient evaluation?
As mentioned, majority of these patients are asymptomatic. So in a patient with a chronic kidney disease by itself is an risk factor for development, maybe because of the biology, because of the multiple inflammations and chronic changes presenting to the kidney. They need to be on the watch. If they find any suspicious mass in the kidney, they need to evaluate it. Ultrasound still remains, as sir mentioned initially, ultrasound still remains a very useful screening tool. And the other thing is that any patient with hematuria, that is the passing of blood in the urine, should be evaluated in detail. This should include imaging. This should include necessary, because it can arise anywhere from the kidney to any other part of the genitourinary tract. The third thing is that patients with an increased risk of developing kidney cancers, as sir mentioned, VHL, all the genetic patients with genetic markers or a phenotype, they need to be screened on a regular basis.
Sure, sir. Dr. Gupta, you want to add something?
No, this actually sums it up very well, that we need to, basically the nephrologists have to be aware, because all the chronic kidney disease patients, they are at an increased risk of developing renal cell carcinoma. So while they are treating the chronic kidney disease, any unusual lump or a mass which develops in the kidney, they should be vigilant about it and promptly refer or evaluate the patient to a urologist or to an oncosurgeon.
Sir, you did mention that currently there are no proper biomarkers. So are there any emerging biomarkers in kidney cancer diagnosis or prognosis? And how are they influencing treatment decision?
I'm sorry, I didn't get your question.
So are there any emerging biomarkers in kidney cancer diagnosis and prognosis? And how are they actually influencing treatment decisions?
No, as I said earlier, basically renal cell carcinoma, the biomarkers which are there are certain biomarkers, but they have not been validated in a proper clinical trial. They have been at an experimental level. So there is no real biomarker which we can use to diagnose or to screen a renal cell carcinoma.
Okay. Sure, sir. Thank you so much to both the doctors. I think for talking about screening and diagnosis definitely helps you in early detection. I now talk about some questions which are around management and treatment of kidney cancer. So my question is to Dr. Gupta. So what are the common post-operative complications after radical nephrectomy that you see?
Okay. First, let me just tell you about radical nephrectomy. Radical nephrectomy is the process or is the surgery in which the kidney along with its covering fascia and its blood vessels is removed. So the renal cell carcinoma stays inside that fascia when in the early stages. So a radical nephrectomy is a surgery which completely removes this tumor, especially early stage renal cell carcinoma. Now the complications of this are that they can be, because the kidney is a vascular organ, there is a risk of having post-operative hemorrhage or bleeding. Now, this is there in about 15 to 20% of cases, because there might be a slippage of ligature, or this involves a large amount of dissection. So, post-operative bleeding is one of the major complications of radical nephrectomy. This is an open surgery, and this also applies to minimally invasive surgery. Then the other complication can be, because the other kidney might also be diseased, so there can be a risk of uremia. So there can be a risk of that the other kidney might not function properly. Then there can be complications related to the surgery, like there can be a post-operative ileus, there can be um, infectious complications. Then because of the surgery, the patient might not be able to breathe properly. So there can be lung collapse, that is atelectasis. So patient can develop pneumonia. So there are a whole lot of complications which can occur post radical nephrectomy.
Dr. Nikhil, you want to add something?
Yeah, in addition to what sir said, which are the classic adverse effects which we should be aware about, I have something to put from a physician's perspective that kidney cancer is known to have a hypercoagulable state. So the formation of clots, especially pulmonary, I'm not talking about the tumor embolia, I'm talking about the pulmonary venous thrombosis is quite common. So that is another thing we should be very careful in the post-operative period. So you do have increased risk of bleeding, as sir mentioned. At the same time, you also have increased risk of clotting in these patients.
Moving ahead to my next question. Now, this is for Dr. Gupta himself, because you were doing laparoscopic nephrectomy. So in terms of laparoscopic partial nephrectomy, what would be the indications for this?
See, the indication for a surgeon is that if it is technically feasible, then you should go ahead and do a laparoscopic nephrectomy. Though classically it is said that any tumor which is less than 10 centimeters, you can do a laparoscopic nephrectomy. But a laparoscopic nephrectomy is generally not possible for tumors which are in the central part of the kidney. That is the place where it is, because it is generally feasible more in a upper pole or a lower pole of the kidney. Then laparoscopic nephrectomy can be done in almost all cases, and it should be done in patients who got a single kidney. So then you should try not to do a radical nephrectomy. You should do a laparoscopic surgery. Then when there are multiple tumors, when there are tumors which are bilateral tumors, then patient whose kidneys are not functioning properly, all these are indications for a laparoscopic partial nephrectomy.
Sure. Dr. Nikhil, you want to add something to that? Okay. Moving ahead, I think my next question is around current recommendations for adjuvant therapy after surgery in patients with localized kidney cancer at high risk of recurrence. How do these recommendations differ based on individual patient characteristics? Dr. Gupta, if you want to take that.
See, basically, renal cell carcinoma, that is operable renal cell carcinoma, is divided into low risk, intermediate risk, and high risk. So based on the risk factors which are associated with the tumor, there are certain adjuvant therapy which is recommended. For low risk tumors, there is hardly any adjuvant therapy which has been indicated. But for intermediate risk and for high risk tumors, there is adjuvant therapy has been recommended. So these high risk factors include tumors which are of large size, that is T3 or T4 tumors with lymph node metastasis, sarcomatoid variants of clear cell carcinoma. So these are the things on which in stage 1, 2, or 3 tumors also, but you can give adjuvant therapy. But Dr. Nikhil would be able to add more on this.
Thank you, sir. The recent recommendation, as sir mentioned, will be for the high risk or the intermediate risk patients. Any stage T technically may be, a candidate for an adjuvant pembrolizumab. That's the only immunotherapy agent, programmed death ligand inhibitor, which is approved as an adjuvant based on the keynote 564 trial. Now, that has shown a disease-free survival advantage over placebo. Now, even certain stage 2 cancers, as sir mentioned, sarcomatoid and rhabdoid features, high grade, that is grade 4, all these may also be considered for giving adjuvant. Observation still remains a reasonable option for intermediate risk or a low risk patient In fact, that should be the standard of care for a low-risk patient. In certain selected situations, a multikinase VEGF inhibitor like sunitinib, based on a extract, that is, there was initially TKAs were tried a lot in the adjuvant setting. Out of that, only one trial had a positive finding. So very carefully you can select, and in patients whom logistics for immunotherapy may not be possible and they do not have a significant renal dysfunction, I think given sunitinib can be offered in very selected patients. Otherwise, it is observation or pembrolizumab for the high-risk patients.
Sure, sir. Moving ahead, sir, we will talk about recent advancements in the field. So, I have a question for Dr. Gupta. Sir, how can nephrologists collaborate with oncologists in the monitoring and management of kidney cancer patients undergoing, let's say, systemic therapies, particularly regarding renal function monitoring and dose adjustment?
Yeah, basically the nephrologist is a very key person in the management and in the follow-up of such patients, because most of these patients ultimately, one is that for follow-up they will come to the nephrologist. So the nephrologist is the first person of contact for these patients. They are monitoring the renal functions of these patients, so they will be closely monitoring that, and that is important because the other kidney, especially if a radical nephrectomy has been done on one side, then the other kidney is at risk for developing progressive renal dysfunction. So the nephrologist has to be in close sync with the oncologist. Plus, they have to also be on the lookout for a development of a synchronous primary. So that is why the renal cell carcinoma patients have to be, both the oncologists and the nephrologists have to work together as a team.
Sure. Dr. Nikhil, you want to add to that?
Just to reiterate points told by sir, we do need the nephrologist because these patients, especially if they have undergone a radical nephrectomy with a solitary kidney, they're going to have some renal dysfunction. They're going to be hypertension and probably other, as India is the diabetes capital, that is going to add further strain to the remaining kidney. So we need the support of nephrologist and a proper kidney health in continuing therapy. Similarly, a lot of our drugs, let it be the multikinase inhibitors, or even some of this immunotherapy can have some idiopathic nephritis, autoimmune nephritis, etc., which require the help of a nephrologist in maybe both diagnosing, differentiating, and supporting us.
Yes, sir. Yeah. Dr. Nikhil, my next question is to you, sir. So, what are the implications of kidney cancer and its treatment on the overall kidney function? And let's say the risk of developing CKD or end-stage renal disease in the long term?
Yes, I had addressed this. We had already addressed this point in the previous discussion. The anti-VEGF tyrosine kinase inhibitors generally lead to a proteinuria or a glomerular disease of the kidney, which causes excess secretion of proteins. It also leads to what is called as a afferent arterial vasoconstriction, leading to maybe like an acute kidney injury like presentation, which over time can become chronic in nature. So through various mechanisms and toxicities, our own therapies will add to the burden, especially if you have one kidney band. Even in patients who undergone a partial nephrectomy, some form of a dysfunction, it may not be decompensated, but some form of a renal dysfunction is present. And the proteinuria can be distressing in certain drugs. Similarly, nephritis, autoimmune nephritis with the drugs such as, I have had a patient whom, thanks to the timely diagnosis based on just a urine sample, we were able to start steroids and salvage him from going to irreversible kidney injury. So both immunotherapy and VEGF inhibitors, which are our mainstay in systemic therapy, do have, especially the VEGF inhibitor, do have kidney toxicity.
Sure. Dr. Gupta, you want to add something?
No, he is covered it. He is a physician. He's dealing with all this every day.
Sure, sir. Moving ahead, I have a question for Dr. Gupta.
Yeah.
Sir, what would be the evolving surgical approaches in the treatment of kidney cancers, and how do a minimally invasive technique compare to the open surgery in terms of oncological outcomes and the recovery of the patient?
This is a question after my heart. See, the basically minimally invasive, the word itself means that it is minimally invasive. So uh, instead of a large big incision through keyhole or keyhole incisions, the instruments are inserted into the peritoneal cavity and the mass is removed. Now, as far as what is the way the world is going, so robotic surgery is the way which the world is going. Now, there are two ways. The robotic surgery is also a way of laparoscopic surgery only, but the thing is that the surgeon sits at little further away from the patient, and the robotic arms do the surgery, which is controlled by the surgeon. Now, there is a difference between laparoscopic surgery and robotic surgery. Robotic surgery is there is much more precision in robotic surgery. The degree of freedom of the movement of the arms of the robot are much more compared to laparoscopic surgery, which leads to a much more precise excision of the tumor. So you can do a partial nephrectomy with a much greater degree of precision and a better tumor clearance in a robotic surgery. Now, when we talk about oncological outcomes, there have been no head-to-head trials comparing robotic surgery to laparoscopic surgery, but there are plenty of trials which compare open surgery to laparoscopic surgery. And in all these trials, they have found that laparoscopic surgery, oncologically, the outcomes are almost same, if not better, due to the earlier post-operative recovery and less amount of pain. So, robotic surgery is being performed for majority of renal cancer surgeries, especially partial nephrectomies, and laparoscopic surgery is being done where robotic facilities are not available.
Sure, sir. Thank you. Dr. Nikhil, if you want to add something to that, sir.
I have nothing to add. It was very, very clearly put across.
So I
There is
have
a tendency in lot of centers to go for a robotic. For example, our center, we do quite a bit of robotic cases, but as sir clearly put it, there's no head-on trial between laparoscopic. That should be the take-home point which sir has mentioned. There's no head-on trial. It should be, we are extrapolating, and the outcome should be, oncological outcome should be comparable.
sure. So then for that matter, Dr. Gupta, I have another question for you, which
Yes.
is on, we talked about robotic surgery. So what are the contraindications for robotic surgery in kidney?
Okay. So the contraindications, of course, the contraindications means actually there are no real contraindications for robotic surgery. Robotic surgery can be done in almost all cases. Yeah, even I have not done, but I've seen people doing robotic surgery for patients with inferior vena cava thrombus also. So robotic surgery is possible for. The only thing is that in our country, especially robotic surgery, cost is a big factor. The consumables of a robotic surgery, they cost quite a bit. So a lot of our patients are not able to afford robotic surgery. Otherwise, and maybe if previous too many surgeries have taken place, so the abdomen is, it's not possible to enter into the abdomen, then it might be a contraindication. Otherwise, there is no real contraindication to doing robotic surgery.
Sure, sir. Moving ahead, I have another question. Sir, how do we approach management of kidney cancer in patients with pre-existing CKD or those on dialysis? What are the treatment considerations and potential challenges in this population?
Yeah, so basically you have to optimize the kidney function. That is the key point. Now depends, and secondly is that you should try to save or do a partial nephrectomy so that the ipsilateral kidney is able to function, plus the contralateral kidney, because CKD or chronic kidney disease generally affects both the kidneys. So if you have to do a nephron sparing surgery, that is, you try to save the kidney, that is by doing a partial nephrectomy, and preoperatively you optimize the patient, like controlling his or her hypertension, giving the patient dialysis, and making sure that all the other comorbidities are under control, then I'm sure the patient can be managed successfully.
Sure. Dr. Nikhil, if you want to add something to that.
Yeah, sir, these are very challenging cases. What I understand, when you sit in the uro-oncology tumor board, I remember saying the surgeons that, just so that the maximum kidney function is retained in patients who maybe are not dialysis dependent, or who are almost going to be dialysis dependent, even a one nephron or one cell line of margin is enough, and that is when they take the surgery. We look at the margins when we operate and remove the tumor specimen. So they say even one cell margin is enough in a partial nephrectomy. So they are observed. I mean, the surgeons do keep all his consideration in mind. And as sir mentioned, the preoperative optimizing of the renal function, the BP, the sugars, all play important role, including the protein, the general albumin in the body, all play important role in better outcomes.
Sure. Yeah. Moving ahead, I have another question from Dr. Nikhil itself. So, could you talk about the recently approved chemotherapies for kidney cancer?
Yeah. So, Darshika, the terminology is there is no recently approved chemotherapies for renal cell. It has been proven to be a chemo-resistant disease. So, the newer advancements include immunotherapy. So, in 2008, actually, the tyrosine kinase inhibitors were one of the first drugs in a metastatic RCC to make a difference in outcomes. We had sorafenib, then later on sunitinib, pazopanib come. Now you have the third generation of drugs like cabozantinib, axitinib, lenvatinib, etc. They all act on multiple molecular pathways, but the predominant driving anti-tumorigenesis activities through inhibition of the vasoendothelial growth factor receptors. But they have other, they all have the individual blockade and causing tumor control. The immunotherapy is what revolutionized RCC management. Historically, there was immunotherapy. They used interleukins, interferon alpha in the management of kidney disease in the past, maybe in the late 90s and early 2000s. But they were very toxic therapy, and outside of, maybe in research university, they were difficult to replicate in a day-to-day practice. The PDL1 inhibitors, the programmed ligand inhibitors and programmed inhibitors are what transformed the outcomes in an advanced, inoperable or metastatic RCC. So nivolumab was initially approved in the second line. Then, as with any of these agents, they try out in the first line and they get their respective approval. Then right now, the standard of care is common, especially when we look at what is called as a risk criteria. There's something called a Heng's risk criteria or IMDC risk criteria, based on which high-risk patients and intermediate risk patients should be offered a doublet therapy. Either you give them a combination of immunotherapy with the anti-VEGF TKI. Examples will be pembrolizumab with either axitinib or lenvatinib, nivolumab with cabozantinib, or we can give even a combination of immunotherapy plus immunotherapy. That is nivolumab plus ipilimumab. Ipilimumab is an anti-cytotoxic T-cell lymphocyte antigen inhibitor. So this together have, we have complete response also. Previously, with the TKI alone, we used to have maybe around 2%, 5% complete response. Now we have as much as 15% complete response in certain cases. And even after stopping of immunotherapy, due to the memory cells may be present against the tumor, some good biology RCCs do survive for 3 years, 4 years post, stopping immunotherapy also.
Sure. Dr. Gupta, you want to close this for that?
No, this is purely a medical oncology field. But yes, I want to highlight that the scenario for stage 4 kidney cancer has changed completely in the past 10, 12 years because of the introduction of so many new molecules. And so what was a very dismal disease, a disease with very dismal prognosis, patients are surviving for 2 to 3 years, even more. And that is what has given a boost to the treatment of renal cell carcinoma.
Awesome.
But I would like to add one more thing in this setting, where sir might have more experience. Even now, in a patient who, as I said, we risk stratify in a metastatic disease and they have a good risk, a cytoreductive nephrectomy. Like, it is not a nephrectomy that achieves cure the site, but it reduces the burden of the disease. It is also improves overall outcome. And there's of course a role for palliative nephrectomy also in patients who are very symptomatic.
Yeah, cytoreductive nephrectomy. Earlier, we used to do in all cases that the moment we used to believe that you remove the kidney and your drugs will work better. But now we have found that it doesn't work that way in all cases. But yes, if there's low risk disease or if there is the metastatic load is very less, then definitely there is a role for doing cytoreductive nephrectomy.
Awesome. Yeah, thank you so much. We now go to our last leg of question answer, which will be more about interdisciplinary or a multidisciplinary team management. So, my question is for Dr. Nikhil to start off. Sir, how do we address the psychological or the emotional impact of kidney cancer diagnosis and treatment on patients, and how can nephrologists or the current team provide holistic support during patients' journey?
Oncology is always the secret of oncology. A good oncological outcome is always a multidisciplinary approach. As you are aware of the theme of this World Kidney Cancer Day is living. We have to live with that. Means it's also talking about not just living with the adverse effects, living with survivorship. This talking also about a social support, emotional support. Now, a lot of these patients do feel a distress at the end of the day because a part of their but the survivors, a part of their body is gone. And even patients with the metastatic disease may survive for a long time. They have a lot of toxicities they have to deal with. A good psycho-oncology, team can help, improve overall outcomes and quality of life factors, with timely intervention, discussions, behavioral therapies, etc. Of course, in our busy day-to-day schedule, we do miss some of the nuances, small nuances. In ideal scenario, we should include psychologists in our treating team.
So, Dr. Gupta, you've been working this for almost 3 decades. Any patient stories or if anything that you would want to share on this aspect?
Basically, the management of renal cell carcinoma, especially if it is caught early, is very gratifying. That is because you can be quite sure that you can cure the disease. And what is known as stage 3 renal cell carcinoma, when there is a thrombus in the inferior vena cava, the management of such patients can be very challenging because to remove the tumor from the inferior vena cava, especially if it is going up till the right atrium, is extremely challenging. And we've had a couple of patients which I have operated on where we put the patient on cardiopulmonary bypass and remove the thrombus right up to the right atrium and remove the thrombus along with the kidney. And the patient has had a good 5-year survival. So these are very gratifying stories because they tell us that, we should never give up while treating renal cell carcinoma. And especially with now the availability of all the immunotherapy and checkpoint inhibitors and the TKIs, it is so gratifying and so heartening that all patients with renal cell carcinoma can be offered some line of treatment or the other, and which can add a which can add meaningful years to their life, and the quality of life can be very.
Sure. Thank you so much. Moving on to my next question. How can, I think we have discussed the role of nephrologists, but how can they
Yes.
contribute in the multidisciplinary care of kidney care patients, particularly in terms of renal risk assessment, optimizing fluid, electrolyte balance, and also managing the comorbidities such as hypertension or proteinuria, as you mentioned? So, Dr. Nikhil, if you want to start with that.
Yeah, you have answered the question already. So that's how they are going to help us. They are going to keep an eye on the other kidney. They are going to optimize the kidney function, manage all the good BP control, sugar control, advise them on the diet. Diet also needs to be focused upon for kidney cancer patients, especially those with chronic kidney disease.
Sure.
And, they'll also help us in the surveillance of the, for metachronous primary in the other kidney, etc. They'll help us in surveilling and early detection of another kidney tumor or cancer.
Dr. Gupta, over to you, sir.
Yeah, I think this we had already discussed. So the nephrologist is a key part of the team, both in the post-operative management, especially if the kidney function deteriorates, and then we involve the nephrologist in it so that the kidney function can be optimized both pre-operatively, intraoperatively, and post-operatively. So he's a vital member of the team. And as he rightly said, that in the surveillance part of it also, they are the first point of contact. So they are important in the overall management of kidney cancer.
Sure. Now this brings me to the last question. And I would give this to Dr. Gupta to start off because of his experience. So, sir, how can doctors stay updated, let's say, with the rapidly evolving advancements in kidney cancers, diagnosis, management, and also what are the resources or educational opportunities would you recommend? Because we also have many budding KOLs or students or who would want to, physicians or surgeons who want to actually take up, oncology as their super specialty. So, Dr. Gupta, how would you suggest?
As far as staying updated to all the information, there is an information overload in the world. There are so much of information coming out. There are articles published every day. So it is almost impossible to stay abreast with whatever is taking place in the world. So obviously, because of this, you cannot, it has been said that you have to read so many hundreds of journal articles just to stay abreast of your specialty. So there are all these websites are there. There are these YouTube videos are there. There are the medical websites like your own. So that is one of them. Then, of course, yes, a strong mentorship is very important. That the students especially, they need to find a good mentor who can, guide them in their paths to wisdom and knowledge. Yes, Nikhil?
It is. I agree with sir that there is a overload of information, even in specialty especially specialty like oncology. One of the beauty of oncology is that you have to keep yourself updated, and then some form of an automatic updation happens, especially when you are working in a institute. But then I think the way forward for now, unlike our seniors and peers like Gupta sir, we won't have the capacity to learn a lot. So I think we should pick our focus areas. For example, I have selected uro-oncology, where we'll be able to go a little more in depth. At the same time, we should have our basics should be strong in general, whichever specialty we are doing. But we can go into focus area, build up a practice, do the legwork required, and that will keep us shoulders above our peers.
Sure, sir. Thank you so much. I would now request both of you to give me closing remarks for today's, session and any key takeaway message. I think Dr. Nikhil has actually given out key takeaway messages all throughout the discussion, pinpointing the pointers, but anything you would want to close upon. So Dr. Nikhil, we want you to go first.
One key takeaway at the end of the day is prevention. Another possible thing I can point out with specifically to kidney cancer is once we reach the age of 50, a general checkup, which includes maybe an ultrasound abdomen, which doesn't have any long-lasting adverse or any long-lasting effects, is a useful tool. It may not be a very scientific tool. There's not going to be any, I mean, this has been tried out, screening ultrasound, but then it is a effective and relatively inexpensive tool. The other thing is abstinence and cessation from smoking and to some extent alcohol to reduce the risk of kidney cancers, and lifestyle changes, of course.
Sure, sir. Thank you so much. Dr. Gupta, sir, over to you.
Yeah, I would also like to reiterate the same things. Basically, it is the lifestyle modification. We have seen there has been an explosion of diabetes and obesity in our country, and the youth are attracted towards smoking. So this is leading to increased incidence of kidney cancer. So plus there is a rampant misuse of non-steroidal anti-inflammatory drugs and exposure to all the environmental carcinogens like benzene or the petroleum-based products. These are some of the known risk factors. And if we can avoid them, if we can protect ourselves, then I'm sure this is a disease which can be easily be controlled.
Sure, sir. Thank you so much. I would like to express my deepest gratitude for our panelist speakers, Dr. Samir Gupta and Dr. Nikhil, for, of course, participating in this webinar on advancements in the diagnosis and management of kidney cancer under the Docplex's World Kidney Cancer Conference. It was truly insightful and engaging experience, and we are very grateful to Docplex's internal teams also and our experts present here for making such an educational event possible. I would also extend my appreciation to the entire Docplex's team for their tireless efforts in planning and executing the conference. Dear team, your dedication and attention to details were evident throughout the entire process, ensuring a seamless and successful event. I'm also grateful to all our doctors who participated in the conference and for your valuable contributions and insights. The diverse perspectives and the expertise shared during the program added immense value to the discussion, hence enhancing the learning experience for all the participants. Lastly, I would like to thank all the participants who attended the webinar. Your active participation and thoughtful questions truly made the session meaningful and rewarding. It was a pleasure to interact with such an enthusiastic and knowledgeable audience. With this, we close today's session. Thank you so much. And I will see you all soon in another clinically rich discussion exclusively on Docplexes. Until then, please take care. Have a great evening. Thank you so much, doctors.
Thank you.
Thank you so much.
Thank you, sir. Bye, sir.